Before we hit the 5 mistakes, I'll give you that hospital shield game plan so you're protected from minute 1. Pre-game plan, your 1-page hospital shield. Here's your protection you can carry in your wallet. A single page that tells the hospital exactly who you are, what you can do at baseline, and what keeps you safe. At the top, write your full name, date of birth, and 2 phone numbers, your healthcare proxy or power of attorney, and a backup. Under that, list your current medications with doses and timing, plus any allergies and what reaction you had. Don't leave it at nausea or rash. Be specific so they take it seriously. Next, define your baseline function in 1 sentence. For example, walks household distances without a device, climbs 12 stairs with a rail, handles own toileting, uses hearing aids and glasses. This matters because the team often meets you at your worst moment and assumes that's normal. When they know your baseline, every decision can be measured against getting you back to it. Now the goals box. This is where you set the rails. Write 3 to 5 clear outcomes in bold. Home walking like before. Up to a chair for all meals. Walk 3 times a day with assistance. Avoid benzodiazepines. Z-drugs, diphenhydramine, hydroxyzine. No Foley catheter unless true urinary retention, surgery, or strict output needed. Prevent delirium. Keep glasses, hearing aids, daylight, quiet nights, and low-dose melatonin only if needed. Add 1 line that changes everything. Call my advocate before any new test, medication, or tube. Put the phone number right next to it in large print. This makes your loved one part of the team instead of a visitor. Include a status and safety section. Your code status if you've decided it, any fall risks, and special needs like language or cognition. Add a short note. High risk for delirium. Use non-sedating options first. That sentence alone prevents a surprising number of nighttime missteps. Finally, at the bottom, print the 3 words that anchor every choice. What's our goal? Train yourself and your advocate to use it before any CT, MRI, for line, catheter, or sleep medication. Follow it with one of these. Will this result change treatment today? And can we remove it today for any tethers? Print 5 copies. 1 for your wallet, 1 for your refrigerator, 1 in your glove box, 1 saved as a photo on your phone, and 1 for your advocate. When you arrive at the hospital, hand it to Triav, the first nurse, and the admitting team. Then hand it again at shift change. With that shield in place, you're ready to block the first and most expensive trap. Mistake number 1, the just-in-case CT/MRI Cascade. This one starts with good intentions and ends with a biopsy you never needed. Why is just-in-case imaging pushed so fast? 3 reasons. First, liability fear. If something rare is missed, everyone gets blamed. Second, default protocols. Many emergency order sets trigger scans by reflex. Third, quick billables. Imaging is fast, available, and financially aligned. But here's the catch. Older adults pay the price in cascades. Let's make the risk concrete. Incidentalomas, findings unrelated to why you came in, show up on about 30% of abdominal CTs and around 10% of brain scans. There's even a term for the harm that follows. Vomit, victims of modern imaging technologies. A harmless spot becomes a new problem. That means more scans, needles, bleeding risks, infections, and you lying in bed waiting between each step. Bed rest alone costs you about 1 to 1.5% of strength per day, stacking up toward 20% in 2 weeks. That's how a quick look becomes a month of recovery. So what do you say when the tech is already at the door? Start with your shield and the 3 words, what's our goal? Then ask the pivot question, will this result change treatment today? If the answer is no or it's a baseline, you have room to pause. Use the time box rule. If you're stable with no red flags, ask for observation and repeat checks for 6 to 12 hours before scanning. Most chest pain, most belly twinges, most lightheaded episodes declare themselves with serial vitals, a bedside exam, and targeted blood work. Many resolve without radiation, contrast dye, or the bed-locked wait for transport. There's a safer swap that professionals respect. Propose a bedside exam plus repeat vitals at set intervals and a targeted lab panel tied to your symptoms. Example: for dizziness without head trauma, start with orthostatic vitals, hydration, and a careful neuro exam. For vague belly pain without peritonitis, ask for serial abdominal exams, basic labs, and pain control first. For chest tightness with normal EKGs and troponins, continue monitoring and walking trials with assist before a CT. Now, exceptions matter. Do not delay when the window is real. If stroke symptoms started within the treatment window, if there's head trauma with red flags like loss of consciousness, vomiting, or new weakness, or if your belly exam shows peritonitis, severe guarding, and rebound pain, imaging can be life-saving. Your shield isn't a brake, it's a steering wheel. It helps you avoid the default when the default isn't helpful. Here's how the script sounds at the bedside. What's our goal with this scan? If the result won't change what you do today, can we watch for 6 hours with repeat checks? Could we do a targeted exam and labs first? I'm concerned about incidental findings leading to procedures. How do we avoid that if the scan shows something unrelated? This language keeps the team on your side. You're not refusing care. You're aligning care with outcomes. A fast micro-story to lock it in. A 78-year-old with brief chest pressure arrives calm, stable, and pain-free. The default order set includes a CT pulmonary angiogram. Her advocate uses the goal question. The team agrees to serial EKGs and 2 troponins over 3 hours, both normal. She sits up for meals, walks to the bathroom with assistance, and her symptoms don't return. No CT, no dye, no incidental nodule to chase. She sleeps at home that night and avoids a $7,000 observation bill plus a week of scan-related anxiety. But here's where most people mess up. They agree to the scan, then forget the second half, asking how to handle incidental findings if they appear. Before the scan starts, ask the clinician to define thresholds. If you see something unrelated and low risk, can we plan to discuss outpatient follow-up instead of in-hospital procedures? This pre-commitment reduces the chance of an automatic biopsy at 2 a.m. Another mistake is thinking MRI is automatically safer. While there's no ionizing radiation, MRIs still uncover incidental findings and can keep you off your feet for hours. If the MRI requires sedation for claustrophobia, your delirium and fall risks jump. Use the same questions. Will it change today's plan? Are there non-sedating ways to complete it? Can this be outpatient? And one more pivot worth learning. Walk when safe before you scan. If your symptoms ease and your vitals are steady, ask for a supervised hallway walk. It tests real function and can reveal who actually needs more workup. If walking worsens symptoms or drops your pressure, that's useful information. If it doesn't, you've proven stability and often avoided the dominoes. Tie it back to your shield. Hand it over. Use the scripts. Ask for the time box. Agree to immediate imaging only when the benefit is clear and time-sensitive. This one decision point, stopping a reflex scan, can prevent the entire cascade. No bed rest, no catheter for transport convenience, no sedative for an MRI, no surprise incidentaloma, no invasive procedure you never needed. Once you avoid that first domino, everything else gets easier. Mistake number 2, automatic bed rest and Foley catheter. Once that reflex scan is off the table, the next trap shows up quietly. A nurse says, "Let's keep you in bed for now." And someone reaches for a catheter just to make things easier. Easier for whom? Bed rest and Foley's are convenience tools that quietly drain strength and invite infections and confusion, especially in older adults. Remember the hard math. Every day flat costs around 1 to 1.5% of muscle. In a week, stairs feel harder. Reaction time slows. A small stumble becomes a fall. Add a tether like a catheter or an for that never gets removed, and you've cut your chances of getting out of that bed on your terms. Here's why it happens. Hospitals are built for monitoring and speed. Bed alarms, catheters, and NPO after midnight policies reduce staff steps, not fall risk. The problem is that catheters are one of the fastest routes to a urinary tract infection. Infections spike delirium. Delirium drives more sedatives, which spike falls. That's the cascade. More bed rest is not a treatment. It's a risk factor. So make your stance simple and early. Use your hospital shield and say, no Foley unless there's true urinary retention, surgery, or strict hourly output needed for kidney or heart issues. Those are legitimate reasons. Convenience is not. Before any catheter, ask for a bedside bladder scan. It's painless and fast. If the bladder isn't full, you don't need a tube. If it is full and you can't pass urine, then a short-term catheter with a clear plan to remove it within 24 to 48 hours is reasonable. Put a stop date in the order. Next, replace bed rest with a mobility order that reads like a prescription, up to chair for all meals. Walk 3 times per day with assistance. Sit on the edge of bed for teeth brushing and grooming. Ask the nurse to chart ambulation like a vital sign. Steps are data. When walking is on the whiteboard, it becomes part of care, not an afterthought. Request physical therapy and occupational therapy within 24 hours of arrival. Their notes can unlock equipment, home health services, and safe discharge. Now, you might hear they got dizzy when we tried. Good. Now we have a clue to treat. Ask for orthostatic vitals, hydration, and a medication review. Blood pressure drops when you stand. Adjust fluids. Time blood pressure meds earlier in the day. And try again with support. New weakness? Try sit to stands from the chair, marching in place, and heel raises before hallway walking. The goal is progressive mobility, not heroics. Watch for tethers that masquerade as safety. A bed alarm without a plan to mobilize just trains you to stay put. And 4-pole, in case we need it, becomes a leash. Use the script. Can we remove it today? For any line, catheter, or alarm. If the answer is no, ask, what has to change so we can remove it tomorrow? Get that condition on the board. Nighttime is where this trap deepens. Instead of a catheter to avoid bathroom trips, ask for scheduled toileting. Offer assistance every 2 to 3 hours and before lights out. Pair it with a clear path, non-slip socks, and a night light. Keep your glasses and hearing aids within reach. These simple steps prevent the 2 a.m. sprint that ends in a fall. If the team worries about incontinence, propose briefs or a commode at the bedside as a short-term bridge while you rebuild strength. A commode beats a catheter every time for infection and delirium risk. And remember, if you do need a catheter briefly for surgery or strict output, set the removal target at the time it's placed. Say, let's plan removal tomorrow morning and reassess with a bladder scan. Here's a quick micro story. An 82-year-old admitted for pneumonia arrives walking with a cane. The night shift places a Foley so he can rest. By day 3, he's confused and pulling at lungs. He's labeled unsafe to ambulate, and rehab becomes the plan. In a parallel case, the Foley is refused. They scan his bladder twice, schedule toileting, sit him up for meals, and walk him to the door with a gait belt 3 times daily. No infection, no delirium. He discharges home with a walker and home PT in 2 days. Where most people slip is thinking they must wait for PT to move. You don't. Ask the nurse or aide for a supervised sit to stand, a transfer to the chair, and short walks. Log each one. If pain holds you back, treat the pain not with sedation, but with timed analgesia before activity. If shortness of breath limits you, sit up, use the incentive spirometer hourly while awake, and try again later. Seal it with 3 lines from your shield. What's our goal? No Foley unless retention, surgery, or strict output. Up to chair for meals. Walk 3 times daily. Say them early, repeat them at shift change, and watch how the trajectory changes. Mobility is medicine. Catheters are not. Mistake number 3, the nighttime sedative swap. You did the hard work. You kept moving, you dodged the catheter, you asked smart questions about scans. Then night hits. A well-meaning nurse offers just 1 dose to help you sleep. This is where many strong hospital stays go sideways. In older adults, sedatives like benzodiazepines and Z-drugs don't just make you drowsy. They scramble balance, slow reaction time, fog judgment, and spike delirium. In several hospitals, over half of patients who fell had one of these meds on board that night. That's not a scare tactic, it's a pattern. And the fallout is real: a broken hip, a rapid response call, or a new antipsychotic layered on top for agitation. Suddenly, you're too groggy to walk with therapy in the morning, and discharge slips from tomorrow to next week. Why does this happen so often? Night shifts are stretched thin. Alarms, vital checks, and roommate noise make sleep hard. Writing for a pill feels faster than fixing the environment. Add the myth that it's only 1 dose, and the trap is set. But for older brains, a single dose can linger into the next day. Longer-acting drugs stack up. Antihistamines like diphenhydramine or hydroxyzine carry anticholinergic effects that worsen confusion. Zolpidem can unmask sleepwalking or balance issues at 2 a.m. Benzodiazepines, cloud memory, and coordination. None of these help you pass tomorrow's PT walk test. Here's the pivot: trade sedation for a sleep bundle. You'll sound practical, not demanding. Say, "Can we try the sleep bundle first?" Then list what works: lights down, hallway noise minimized, a warm caffeine-free drink, bathroom trip before lights out, your own blanket or socks, relaxation audio through your phone, and low-dose melatonin only if needed. Ask the team to cluster care, vitals, meds, and labs so you aren't woken every hour. Request a door sign. Quiet hours, cluster care. Ask for a white noise machine or a fan hum if available. These steps are guideline-backed in ICU and medical units because they cut delirium without drugs. If pain is the real reason you can't sleep, treat pain precisely. Ask, "Can we time my pain medicine 30 to 60 minutes before lights out?" Short-acting analgesics, heat packs, and positioning beat a sedative every time. If anxiety is the driver, ask for reassurance. "Can we review tomorrow's plan now, so I'm not spinning?" Breathing drills, a brief call with your advocate, or moving an evening diuretic earlier can remove the cause without knocking you out. Use your Shield's medication line to make boundaries clear. Avoid diphenhydramine, hydroxyzine, lorazepam, and zolpidem. Add the sentence that pauses most orders: "I'm high risk for delirium." No sedatives unless ICU-level reason. If a clinician believes a sedative is essential, ask for specifics: the goal, the dose, and the stop date. Then document the morning consequence. If any sedative is given, I need a supervised step test with staff before walking alone tomorrow. That prevents the classic morning fall from residual drug effects. Now, let's address pushback. You may hear, "Melatonin doesn't work for everyone," or "We use a low dose of trazodone." Keep it collaborative. If non-drug steps fail, what is the lowest risk option we can try with the smallest dose and a 1-night limit? In some units, melatonin or gabapentin at low dose is preferred over benzos or Z-drugs. The key is a 1-night trial with a plan to reassess at sunrise. No auto-renewals. A quick micro-story to anchor this. A 79-year-old woman admitted with a mild infection was walking to the chair and eating well. At midnight, she couldn't sleep. A resident ordered Zolpidem. At 5 a.m., she woke groggy, stood without pressing the call button, and fell. Morning PT was canceled, and discharge slid 2 days. In a parallel case, the nurse used the sleep bundle, moved a late diuretic to late afternoon, dimmed lights, and cued soft audio. The patient slept 4 hours, woke clear, walked 60 feet with point at 9 a.m., and went home the next day. One more pattern people miss: screens and timing. Ask to avoid vitals or lab draws between midnight and 5 a.m. when safe. Keep your phone in night mode after 9 p.m. Blue light delays sleep. If you share a room, request a sleep mask and earplugs. If alarms are frequent, ask staff to place louder devices outside your doorway. Seal this section with 3 scripts from your shield. What's our goal? Sleep or safety? Can we do the sleep bundle first? I'm high risk for delirium. Please avoid benzos, Z-drugs, and anticholinergics. If any sedative is given, I need supervised walking tomorrow morning. Night is when your plan either holds or cracks. Hold the line politely. You'll wake clearer. Mistake number 4.